Bismillah ar-Rahman ar-Rahim. Our lecture today is about the pulmonary venous embolism and deep venous thrombosis in the term of venous thromboembolism. Venous thromboembolism, as I said, consists of deep venous thrombosis and pulmonary embolism, as the majority of pulmonary embolism arise from the propagation of the emboli from the lower limb in 80%. Maybe sometime a rare cause due to septic emboli as infective endocarditis or tumor emboli such as choriocarcinoma, fat emboli in the long bone fracture, air emboli in iatrogenic or suction air emboli, amniotic fluid and placenta emboli, especially during the delivery. Incidence, it is not well known, it occurs in about 1% of all patients admitted to the hospital, and it is account for around 5% of all in-hospital death, and it is the common mode of death in patients with cancer, stroke, and pregnancy. We must remember the virtuous stride, which is important in the development of the thrombosis, as it consists of stasis, hypercoagulability, and vessel wall injury. Clinical features start from the clinical features of the DVT, which is characterized by severe cramp or pain in the affected part. إذا أخذنا lower limb فهي بالcalf muscle, و maybe hotness, swelling, dilated superficial veins, where it must be differentiated from the ruptured Baker cyst, which when rupture this cyst behind the knee, it goes into the calf muscle as the fluid content goes to the calf muscle, or it must be differentiated from the cellulitis, which is inflammation of the skin and subcutaneous tissue, which cause also redness, hotness, pain, swelling, but may be associated with fever, chill, that characterize the cellulitis from the DVT, and sometimes we need ultrasound or Doppler study to differentiate between the DVT and cellulitis. In this above picture clearly indicate DVT as swelling, redness, and dilated superficial veins, which is clear, but in the lower picture show the cellulitis as the redness more, and there is also swelling, shiny skin. If we cannot differentiate, we can send to the Doppler ultrasound to characterize the inflammation of the skin and subcutaneous tissue in the cellulitis from the occluded veins in the DVT. Maybe sometime presented concomitantly both in one patient. Another subject is the clinical presentation of the pulmonary embolism, which consists of acute massive pulmonary embolism as the occlusion of the main pulmonary artery or its branches, the right and left, or may cause peripheral small to medium-sized pulmonary embolism as in acute case, or may cause chronic pulmonary embolism as a third presentation. This table shows the differences between the massive, small to medium-sized, and chronic pulmonary emboli, started from the pathophysiology, symptoms, sign, chest X-ray, ECG, arterial blood gases, and alternative diagnosis. We show if we are toward the massive, the manifestation becomes central, chest pain, and severe manifestation, cyanosis, dyspnea, central crushing chest pain, and decreased cardiac output, heart failure. These are closely differential diagnosis to the most important one, which is the myocardial infarction. Another is the aortic dissection, and the third is the pericardial tamponade. While in the small to medium size, the manifestation become peripheral and cause peripheral pain, maybe hemoptysis, maybe pleuritic chest pain, and this should be differentiated from the peripheral chest pain causes such as important pneumonia, pleurisy, musculoskeletal, and another causes. While in the chronic pulmonary emboli, this is the chronic formation of pulmonary thromboembolism, and these include all differential diagnosis of the primary and secondary pulmonary hypertension. Risk factors. Many risk factors lead to the development of the deep venous thrombosis and pulmonary embolism. Most important surgical and most important surgical causes هو major surgical or pelvic surgery, major abdominal or pelvic surgery, hip and knee replacement surgery, and also those who need post-operative intensive care unit, obstetric, pregnancy, and puerperium, and another cardiorespiratory, lower limb, malignant disease, and also miscellaneous, including the previous proven venous thromboembolism, immobility, thrombotic inherited thrombotic disorder, trauma, and etc. The diagnosis. We have a Wells score, the score or another score, pulmonary embolism score, which is most important in the assessment of the presence or possibility of the presence of pulmonary embolism or DVT in this patient. This score is presented in any application in mobile, and this calculates the score according to the 10 questions. Only we answer yes or no when asking the patient these questions, and if present yes, or if not present no. And also there is sometime if the signs of examination, repeating edema, if there is swelling, we must report this in the score, and the score will calculate the risk by the application itself, and give message this is the low risk or moderate risk or high risk. Start from the diagnosis by chest radiograph. Chest radiograph, many manifestation, including the maybe pleural effusion, or maybe collapse that cause elevation of the diaphragm, or may cause wedge-shaped infarction, or mottling infarction, or horizontal lines, or sometime when there is occlusion of the artery, there is decreased vascularity of this part and causing oligemia of this part, and may cause enlargement of the pulmonary artery. Another ECG. In ECG, it is important to exclude the most dangerous differential diagnosis such as the MI, and this ECG may be normal, so it is important to exclusion of the another cause. Maybe there is manifestation starting from the sinus tachycardia, or right ventricular strain, or S1Q3T3, or ST segment depression, or right bundle branch block, or right axis deviation, or atrial fibrillation. Many manifestation of the ECG, but may be normal, so it is important to exclude the differential diagnosis. Arterial blood gases. If there is massive, there is decrease in arterial oxygen blood gases, and there is normal or decreased in arterial CO2, PaCO2, and as become small to medium size, there may be less degree of hypoxia and less degree of the metabolic acidosis. With chronic pulmonary embolism, there is exertional induce of decrease with PaO2, as walking exercise may cause decrease with PaO2 or exertional hypoxia. Another marker is the D-dimer. And D-dimer, it is also need to exclude rather than to prove the diagnosis, as it increases in many diseases. It is the end product of fibrin and fibrin degradation product. This result end result of the coagulation system, and then the enzymes that release the D-dimer. D-dimer may be an increase in sepsis, pneumonia, myocardial infarction, and banana B. So it must be investigated to exclude the pulmonary embolism. If negative, it is the high negative sensitivity, but if positive, it may mean in another disease should be excluded, as we mentioned. So we show this diagram, which if we have patient with venous thromboembolism and send for D-dimer, if the risk or the score is low and the D-dimer negative, so it's exclude. If positive, D-dimer and the risk is high, should treat the patient and then confirm the diagnosis because the risk high and D-dimer positive. If the D-dimer positive and the risk low by the risk assessment by score, then we must repeat the investigation and goes to the most important investigation as the Doppler ultrasound, CT, ventilation perfusion to confirm the diagnosis. If the D-dimer negative and the risk is high, also should repeat or goes to the most important investigation, which is the CT, pulmonary angio, and ultrasound of the leg and other to exclude another differential diagnosis. Imaging, it is most important, is the CT pulmonary angio, which is the investigation of choice for the patient with pulmonary embolism. LAS, which is كانت اللي قبل تستعمل ventilation perfusion scan, which is consists of injection of the technetium labeled with RBC with another inhalation of the colored gas as krypton or xenon, and then show the matching between the arterial blood and the alveolar air. If there is good matching, no problem. If there is mismatch, there may be a problem as in pulmonary embolism or airway problem. This previously used for the diagnosis of pulmonary embolism and ultrasound of the leg to exclude the propagation of the DVT into the pulmonary embolism. And also we have echocardiography to show the right ventricle if dilated, if there is pulmonary hypertension. And there is a Meconiel sign, which is the most important to prove or the diagnosis of pulmonary embolism, as the free wall of the right ventricle become hypokinetic or akinetic, while the apex move normally of the right ventricle. So it is, and also most important investigation to exclude MI or heart failure, another differential diagnosis of pericardial tamponade for the exclusion in pulmonary embolism. And conventional pulmonary angiography, this is previously used and now not used. Management started from the general measure as oxygen and because the patient may be hypoxic, fluid and plasma expander to improve circulation, opiate for the pain, and also for the external cardiac massage for the dislodgement of the pulmonary emboli from the main pulmonary arteries into the peripheral pulmonary arteries to decrease the severity of the patient. Anticoagulation, many anticoagulants are used for the patient with pulmonary embolism. Started from the unfractionated heparin, low molecular weight heparin, oral warfarin, and other anticoagulants which can be used nowadays. Another line of treatment is the thrombolytic. Thrombolytic to lyse the pulmonary emboli, which is important for the severe cases as in a patient with decreased cardiac output, shock, severely cardiorespiratory compromise, or when there is right ventricular failure or severe pulmonary hypertension. We use the thrombolytic and can be used even for 2 weeks presentation of the pulmonary emboli. Contraindication as the contraindication in another disease as in MI, and this أكيد ننطقكم إياها in patient with MI. Caval filter is the filter that can be used in patient with recurrent pulmonary emboli in spite of the anticoagulation, or in patient with contraindication to the anticoagulation, special patient with مثلا كان عنده intracranial hemorrhage and from the immobility of the first few days develop DVT or pulmonary embolism. We can use caval filter through the IV guide catheter into the inferior vena cava and then inflated and to become caval filter to prevent the movement of the thrombus from the lower limb into the pulmonary circulation, as the pulmonary embolism, it is the most dangerous complication of the deep venous thrombosis. Venous thromboembolism and pregnancy, we can, for the diagnosis, can use CT pulmonary angio with fetal shield, as it less risky and less radiation than the ventilation perfusion scan, which is the investigation of choice previously before the CT pulmonary angio for the diagnosis of pulmonary embolism in pregnancy. Warfarin must be avoided because it is teratogenic. The prognosis: patient with pulmonary venous thromboembolism liable for recurrence, especially within the 6 to 12 months, and maybe extend to the 10 years. And if the patient have right ventricular failure, right ventricular strain, shock, those are become or pulmonary hypertension, those are carry the worst or poorest prognosis, as it may remain with decreased right ventricular function, or may remain the pulmonary hypertension in about 4% of these patients. This slide shows different types of anticoagulation that used for the management of the DVT and pulmonary embolism with different mechanism of action. Everyone قدام mechanism of action we can be used for the treatment of DVT and pulmonary embolism. And this is the slide shows the comparison between the unfractionated heparin and low molecular weight heparin, which is commonly used as it's the availability of the low molecular weight heparin, which is more 100%, can be used subcutaneously and have long half-life, less risk of bleeding, less risk of thrombocytopenia. But the heparin unfractionated can be used in patients with severe renal dysfunction when the GFR less than 30, or in patients with cardio pulmonary bypass, in patients with major heart surgery. Heparin, the side effects may cause osteoporosis, may cause increased transaminase, and may cause bleeding, and may cause thrombocytopenia, may cause thrombosis, as it may cause heparin-induced thrombocytopenic thrombosis. Another warfarin, which is act on the vitamin K dependent factors, which are 2, 7, 9, and 10, which is can be followed up by PT and INR. The heparin can be followed by PTT and reversed by protamine sulfate. It may cause many problems, as it has low therapeutic window, that the dose adjustment is very difficult, may cause underdosing or overdosing, and affected by many factors, منها diet, full drugs, and may cause bleeding, and may cause skin necrosis in patients with protein S and protein C deficiency, and may cause teratogenic effect in different parts of mental retardation, bleeding, and periopathy. Thank you for listening. This is the end of this lecture of venous thrombosis.